Hi, everyone. Welcome to Orthopod. I have here three wonderful orthopedic surgeons, two from Africa and one as a colleague at McMaster University. Let me begin first by introducing Dr. Brad Petrozor, who's professor of surgery at McMaster University and has recently taken on a directorship of an international surgery desk. In that role, Dr. Petrozor has been really promoting international collaborations and more importantly, working closely with many of the surgeons around the world to gain insights. And when I say gain insights, it's a shared communication pathway. This is just one of those examples. Welcome, Brad.
Thank you, Mo, and thanks for having me and us. And I'd like to take this opportunity to introduce also Dr. Edward Kironde. Edward works in Mulago Hospital and Nakasero Hospital in Kampala, Uganda. And he also works with the University Makerere and does work with them. He's also an executive member of the Orthopaedic Society of Uganda. So I'd like to welcome Dr. Kironde. And his colleague and our colleague, Dr. Tiondi, works in Kasese in Uganda, which is more in the west, correct? In the Ruwenzori range. So welcome to you both.
Thank you very much.
Thank you very much for taking the time. Edward, I was wondering maybe we'd start with you a little bit and just tell us, you're in Kampala in the city. As our cases in Canada of COVID tend to start to go down a little bit, and we're starting to ramp up. What's going on with you in the city and in Kampala and with respect to COVID? And then we'll talk a little bit more, but what's happening there now?
Thank you very much, Brad. Professor Brad, in the last 3 months or so, we've had 3 events that have not occurred in Uganda in the last 30 years. The first, locusts that invaded the country from Yemen. The second, rising levels of Lake Victoria water levels that have flooded the shores. And the inflowing rivers have also caused a lot of havoc and damaged institutions in the areas. And the third is COVID, all in the same year.
There's seriously some complicating factors around not only COVID, but what else is going on. So how are people dealing with it?
So currently, the country is responding by looking at the government, who have a disaster preparedness ministry that was set up for relief and supporting other relief-funded institutions like Red Cross that are available. But it's still a very tough situation. In the city, we are having a challenge because, as you know, COVID came in around beginning of the year, and all neighboring countries to Uganda had cases reported by mid-March. And by the 19th of March, before we had any confirmed case in Uganda, we had a total lockdown because we are a landlocked country in East Africa, surrounded by very many other countries that have had epidemics. The most recent one was Ebola in 2019. And South Sudan, which is just a new country starting up, so the health system is quite fragile. In the south, we have Tanzania, and in the east, we have Kenya, both of which have a fairly good health systems compared to Uganda. And so when these countries reported cases, Uganda had to go on a lockdown because we are a transit route for road cargo that moves via trailers. And also being strategically located, the Entebbe International Airport is also a transit route for air transport. So as soon as the total lockdown was initiated, we had the first case confirmed at the airport. And
oh, really?
Yes. Those were cases coming in from Dubai.
Oh.
And there had to be mandatory quarantine instituted, and thereafter the cases began to rise. However, because we had a total lockdown, that meant all other services were at a halt. It was the first time it had been experienced by, I would say, the last 3 generations. Even people who are 80 years old had never experienced that. So everyone did not know what to do. Yes.
Yeah.
Essential workers like myself, like Robert, were allowed to get access to the hospital to treat the overwhelming numbers of orthopedic trauma cases, which are very common, and other orthopedic patients who needed treatment. But just to bring in the aspect of what the impact was, so even health workers had a challenge getting to the hospitals. Ambulances had to set up systems to identify patients who needed to get access to hospitals. So there was a bit of a situation where people couldn't access medical services, and those who were already at the hospital had challenges getting the care they needed in time. Yes, so because of that, we had a ward that had a constantly full occupancy of beds, and which is gradually being controlled by a regular output from the OR, being then overflooded because the OR had now less and less output. Being
The OR
system,
had lists, sorry, or?
yes, very few cases, few surgeries were being done because we had to figure out which surgeries had to be done as a priority.
Yeah.
Some workers who were not considered essential and yet were part of the system of running the theaters were affected by the lockdown. For example, those manning the central sterilization systems could not travel to the hospital, so work would stall. Yes.
So they were deemed non-essential then?
Yes, it was still being worked out.
Interesting.
Who was essential and who wasn't, apart from the obvious medical service providers.
Yeah.
Yes.
And how did it change the family dynamic? Because many times patients in the hospital will have family with them looking after things. How did the lockdown change that dynamic with the ward and things?
Oh, it changed it significantly. A case in point is a polytrauma patient who received, who didn't have any family member with him for about 2 days.
Yeah.
Then when the family member managed to get access, it was through help from the institution to get him an official letter. And then thereafter, taking key decisions that required consent became a challenge. Yes. Not only that, we usually have a very communal hospital setting where you have so many family members assisting with patient care or other patient needs. They were totally cut off, so patients were almost stranded. But I think the more difficult part came in when it was time to discharge patients. We had patients who could not travel as far as Kasese, which is over 500 kilometers from Kampala. To go that far, you had to have an ambulance at your own cost, which is very expensive.
And is that because the infrastructure of buses and things wasn't functioning because of lockdown?
Yes, indeed.
Wow.
The only mode of travel was ambulance.
Can I just jump in for 1 second, Edward, and feel free if you want to answer as well, Robert. But when you look to the next, so you've spoken about a very difficult situation in the last 3, 4, 5, 6, 7 weeks or so. When you look to the next 4 weeks, what do you see as your biggest concerns in the next 4 weeks? Because everything we're doing right now is in these 1 month cycles. and just trying to manage the next 4 weeks? What's that look like for you?
As far as Kampala is concerned, the rising number of community cases, our worry is hospitals getting overwhelmed by patients in critical conditions, because we have not had a single death. Because most of the all the patients who've come in, amongst them, majority had just mild symptoms, and they recovered fully thereafter.
Mm.
So we have not had an influx of severe cases in the hospital. That's our worry. The situation where you all need to have ventilators in plenty, oxygen supply, the PPEs in vast quantities. That's our biggest worry.
And so you're seeing cases going up a little bit now then?
Yes, we went from a steady about 50 cases, and then we shot up once the border travel began.
Oh.
And so we're now at over 600.
Oh, really? And Robert, in Kasese, so Edward had mentioned things like locusts and increasing water levels, and you've had some devastating floods in your area. How are things at your hospital? What do you?
Yeah, it's true that we were hit by floods. That happened on the 7th of May. And this is something that has been happening recurrently, I would say. I think the first attack in the recent 3 decades happened in 2013, and this was followed by another in 2014, and then again 2020. But what I must say is what happened in 2020 is a little worse than what we've been experiencing before. In the sense that the hospital is a general hospital handling every cases that come around, with the only specialty being orthopedics. We have 3 colleagues that I work with, and as Dr. Edward already narrated, besides the other disasters that came around, of course, the flood hit Kasese so much. And then, of course, that did not affect only the orthopedic services, but also other areas of services. Now, like this being a rural hospital, an upcountry hospital, which is a private not-for-profit, and then the only hospital in the region that has 3 orthopedic surgeons, we serve a radius of about 400 to 500 kilometers. For those who know Western Uganda, we serve up to Mbarara, where Dr. Kisitu is. And then on the other side, we serve beyond Fort Portal. So we get referrals from all these other districts. And then it being a border district, we get patients from across the border. That is from Congo, and then once in a while from Rwanda through the border with Kisoro, that is Chanika and Chanika border. So really the effect of the flood has hit us a lot, because besides the disruption of other infrastructures like roads and the buildings that we have, we also have disruption of provision of services, because for 3 weeks we are not able to operate. We just started operating last week, and that's why you still see I'm in a theater actor. I just in theater, only took some time off to talk to you. Yes, so it has disturbed the process, but what I must say is we are settling down.
Yeah.
Things are moving on, only that of course we accumulated workload. Were not able to work, so there were many patients who were in peripheral facilities where orthopedic services could not be provided in totality. There were those who were able to operate from whenever they are, from the nearby facilities, but then some work accumulated. So now these are the people who are now coming at this time. These are the people that we need to now offer services to amidst the disaster. But almost what I must say is life has started normalizing. We are moving on, and starting to provide the services. As Dr. Kironde narrated, it's true that we've had a lockdown with ban on public transport. And of course, there has been some minimal movement has been permitted. And of course, both of you, Professor Brad and Professor Bandari, you visited Uganda. You've seen how our border men ride. Yes, so we still continue to get those cases. Bad open fractures, especially tibial fractures, once in a while femur, once in a while upper limb fractures. So we've continued to provide service to the community.
Wow.
You know, the one thing, if I could just jump in again, is time and time again, every other country and every bit of evidence we're seeing, gentlemen, says you have to stop migration. Right now, because we don't have a cure and we don't have a vaccine, the only way to really, what as they're saying, stop COVID. Australia just had their final case, so there's no more cases, sorry, in New Zealand. They did it through absolute strict guidelines for no migration of people. I'm assuming both of you are saying the exact same thing. How strong truly do you believe though, you know, the movement is in terms of stopping that movement? Because I think that will be the key to keeping cases down, is identifying cases and quarantining them and stopping new people from coming into the country.
It is true. Putting a total lockdown would be the best thing in order to control the infection and put everything to a halt. But the biggest challenge we have here is that most members of our population earn from their daily work. You see, someone goes to work in the morning, earns from the workplace, and that is the money that he or she will use to buy food. So much as the government banned public transport, allowed only authorized people, the essential staff, those are the health workers, the security personnel, and those who deal with communication to move around. But people, of course, have to continue commuting from home. In Kasese, people trek more than 15 to 20 kilometers every day to go and do casual work because their source of earning is the work. So because of that, it has been a little bit difficult, say, to put a total restriction to keep people at their homes or to keep them completely within the confines of their home, because their source of earning has been moving from one place to another to buy something. Of course, the good thing is that movement from one district to another has been restricted to some extent. But of course, not keeping off for illegal routes. We have got illegal routes that people can use to move from one district to another, from one region to another. Even international borders are not that secure. People do not follow the formal borders for movement. The border is so porous, so anyone can sneak. The case, for example, that I can give you is how Ebola came from Congo into Uganda. It was not through the formal border. It was through porous routes. That is the border between Uganda and Congo in the district of Kasese. So it's until when we get secure protection of the borders, that's when we shall be able to control things very well. And then, of course, this means that each and every person should be vigilant enough to monitor movements at the border, to be able to report those who could be entering illegally, to be able to report those who could be having signs and symptoms. But as you may be aware, it may at times be very difficult for people to be that vigilant and report each and everything, because there's this social way of living in Africa where people live in extended families. Like, for example, if someone stays on this side of the border, which is less than a kilometer from the other side, from, say, Congo side, if you've got a relative who crossed from Congo side into Uganda, or from Uganda side into Congo, it may be difficult for you to report that relative to the authorities. So really, that is what has been affecting us, especially how porous the border is. But of course, slowly by slowly, people are learning. People are starting to report those who have signs and symptoms of COVID. And that is why the government has been quick enough to start testing at community level. Initially, they were testing mainly at the borders, the borders from one country to another, and then later, and then also, of course, at the airport. But now they have started doing community testing. And this is why the numbers from the community is now on the rise. We are getting more and more people now testing from the communities. And say from the northern part of, I work in the western part of the country, but I originate from the northern part of the country. Now, in the region where I originate from, they're actually getting people who have no history of contact. You see, someone presents with signs and symptoms of COVID, and then he is subjected to screening. This person has no contact. This person has not traveled outside his community, but then he's testing positive for COVID. So that is a sign that somehow the infection is now spreading in the community. And of course, that's something that we should be alert about, and then try to see how best we can control it.
Thank you.
Those are great points, or interesting points. Edward, to those points, we're talking about the porosity of the borders and community spread. And Edward, you had mentioned that the boda motorcycle taxis were increasing. Are they sort of back at work and increasing the internal milieu, you know?
It's only for goods currently after the lockdown restrictions. So that was to promote social distancing, because it was observed that a rider with a passenger have a very close contact with each other, that you lose that aspect of public health prevention. But what we noted was with the border closure, the airport closure was quite effective, because we got no imported cases via airlines. That completely stopped. And then it became very evident that road transport, the truck drivers bringing goods, were the rising number of confirmed cases of COVID. And that actually doubled and tripled and quadrupled the number, but they were entirely truck drivers. And so it was clear that it was imported at the time. But Uganda is a landlocked country, so the drivers traverse from east to west, to north and to south. And along the way, they stop overnight and interact with the community or during their journey. So it looked like the imported COVID cases had a lot of community interactions, and that's what brought up the community tests, which have unfortunately shown that there are cases within the community. Yes.
So with significant external pressures of natural disasters and COVID, what are the next steps for you?
So as a professional, we're trying as much as possible to effectively prioritize our resources. An example is I work on a spine unit, spine ward. Patients who have incomplete spinal cord injuries from trauma are our focus. Well before those who have complete cord injuries, whom the plan is to stabilize, because the few resources we have are not being revamped. So we have more or less a single use for every little resource available. And so we are trying as much as possible to prioritize. One advantage though we've found is at the country level, there's manufacturing of some of the medical supplies that never used to be locally manufactured. A case in point are the surgical masks. And so with a drive towards manufacturing, that will help to cushion some of the needs of the resources. But right now, our goal is prioritization, so as to be able to function and not draw to a halt.
But not only with respect to PPE, have you seen a change in the supply chain of just implants, instruments, that sort of thing?
Right now, yes, it's still a challenge. Implants are a challenge, at the very least, the different suppliers of implants, small companies, startup companies that were able to import. And fortunately, cargo can move in this period of a lockdown, so they're able to bring in some supplies, which are keeping us afloat. Yes, but the demand is far greater than what's available. Yes.
Yeah.
If I could just add one final point from my perspective, which is you are, as I understand, in the rising phase, quite frankly, of COVID, where there are some countries who are saying, we believe we've eradicated COVID from our borders. Africa is still it seems to me very early in its stage, because you've got, rising cases and there's pretty serious concern. That's compounded, as Dr. Petrosor just said, with a flood. You've had a massive flood and that's created problems. And then you also have an infestation of locusts. What is all this like when you talk about the impact of just a flood and locusts? What does that do? And then I guess we've already talked a lot about COVID, but what is the impact alone of just having a flood and the impact of that? And then this infestation that's also occurred. Is that an issue of crops and food? Is it an issue of access to care? What's the impact of just that alone? If COVID wasn't even here, what would have been the impact?
I would say the impact is primarily food security. In a situation where the society had issues with food storage, food supplies, having 2 seasons a year for growing and harvesting, with the floods, the low-lying areas have been affected. So farming has been literally drawn to a halt in an instant. In the areas that were affected by locusts, they were actually very fertile areas. The worry is it happened just at the planting season, and that meant a very young crop. So we have not yet felt that impact, but the projection is very low yields this year. And so food security is really a big concern. Not yet faced it, but it's just a projection at the moment.
Yeah, so
but
it's
maybe
a final thought as we exit out.
Thank you, Professor Brad. It's just slightly before I give my concluding remarks. The effect of these 3 things that you're talking about, like for example, the total lockdown or the lockdown we have, we've got patients delayed to reach our facilities for treatment. Reason being that we've got very poor referral systems, we've got very few ambulances for use by public, and if the patients are to hire ambulances, it's a little bit expensive. So in my region, we have seen patients resorting to traditional treatment, traditional bone setting, where they tend to go to traditional healers in order to try to get remedies to their illness, to their fractures. So because of that, we've got patients who come to the hospital with already complicated fractures. A fracture which was initially closed ends up being open and infected. So that's one of the things. And then 2, we do not have health insurance system for public in Uganda. And that means that our patients pay from what they earn. And now you've got this situation where people are currently not going to work. So we face challenges with that. You get someone who comes to the hospital with a fracture, you fix the fracture, and then at the end they fail to pay their bills. Reason being that they were not able to work in the pre-accident period, and therefore they do not have enough money to meet their bills. And above all, our saving culture somehow isn't good. So because of that, people are not able to even save enough to try to meet their healthcare needs in case something happens. And then in terms of supply of medical materials, like the case in point is implants. Like I'm based in Western Uganda, which is more than 400 kilometers from the center, where we have the implant suppliers are. Now we used to get our supplies through buses that come from Kampala to Kasese. But now you remember that public means has been stopped. So that means that we've got a problem with our supply chain. Our supply chain has been broken. So for some time, we've been using what we already have in stock. But then you realize that with the time, you're running out of, say, screws, you're running out of plates, you're running out of nails, and you need to refill because of the distance and then the lockdown. However, later on, we're able to get a clearance from the authorities. The government authorities are not able to give us clearance so that we can send a vehicle from Kasese to Kampala to be able to procure some items to come. So in my concluding remarks, what I would say is that one, we've tried to cope with the situation, what we have. And then, of course, it has helped us plan better for the future, making sure that one, we use the little resources we have very appropriately. Like, for example, right now, we don't do a lot of elective cases. Say people with the cold cases, we do not pay attention to them as much as we would have if these problems were not there. So right now, attention has shifted more to trying to, one, address emergencies, and then also to sensitize the community so that they understand the problem and then they're able to modify their lifestyle appropriately. Because, you know, trauma is becoming a major cause of burden, morbidity, and mortality of the whole world. And Africa and Uganda in particular is not an exception to that. So that means that from now onwards, we need to incorporate a lot of public health aspects in our day-to-day work so that we try to prevent as much as possible some of these injuries and also some of these infections. So prevention always remains better than cure. So that is what we really need to focus on. And then, of course, appropriate use of resources, rational use of resources, making sure that whatever you use is beneficial to the patient. Yeah, thank you. And of course, thank you for this interaction. It's my first time to interact with you through this channel. I'm so grateful. Thank you.
Thank you so much, Robert. Edward, any final thoughts from your end?
Yes, thank you very much. And thank you, Robert. My final comment on this is COVID has driven us to appreciate what is important. So we're being driven to change and change in a way that we're actually being more rational in our resource allocation, more equitable. We have noted that in this period during the COVID lockdown, when borders stopped and were primarily handling goods transportation, there was a change in the pattern of the trauma. And it looks like, I would say for the first time, we're noticing that the public transport system is making an effort to change the way it is run to reduce on the high risk modes of commercial transportation, like use of motorcycles, to a more organized, less congested transport system, where public means of transport like vans are transporting fewer passengers and their routes are clearly demarcated to reduce on the risk of rushing high-speed road traffic accidents due to not having designated areas of work. In the hospital setting, we are being forced more and more to prioritize, and innovation has come in that light. Also, in the light of reducing congestion, we are also beginning to take up the use of technology more and more. For example, when paying for medications, people are beginning to use the phone services, which are cashless, hence reducing on physical contact. So I think change for the better is really being driven, and I think that's my final thought. Yes.
Well, Edward, I think that's a very insightful final thought, quite honestly, because you kind of think of what unifies us. And I think you said it absolutely, as we're all realizing or trying to understand what is important. And we can deal with COVID and crises and locusts and floods, but you said it. I mean, we're just realizing now in our lives all over the world, you know, what's important. And I just sincerely thank you guys for taking the time, for talking to us, and for being a part of this, and hoping we can do it again in the future. And we're thinking of you, and thanks very much. Thanks, Mo, for having us.
Absolutely. And again, on that note, on that note, Brad, Robert, and Edward, thank you both. Thank you all for a wonderful podcast.